So here we will be discussing about the diseases that occur during pregnancy. The first one is preeclampsia, then placenta accreta, placenta previa, magnesium sulfate regimes, and HELLP syndrome, the hyperthyroidism or thyrotoxicosis in pregnancy, and at the end, hypertension in pregnancy. So while we are discussing this, we introduce ourselves with preeclampsia. The preeclampsia is failure to or invasion of extravascular trophoblasts into the spiral artery. Basic pathology of preeclampsia is endothelial dysfunction that leads to nitric oxide production, decreased nitric oxide production, and vascular spasm. This leads to ischemic changes that result in necrosis, hemorrhage, and end organ damages. When we diagnose a person with superimposed preeclampsia, there are the features like new onset proteinuria, aggravation of hypertension, development of HELLP syndrome that will be discussing as a different topic, development of headache, scotoma, and epigastric pain. In preeclampsia, this can be divided on the basis of the severity as non-severe and severe. The non-severe one, BP, when BP is between 140/90 to 160/110 without significant proteinuria. The severe preeclampsia is when BP is more than 160/110 with other features like proteinuria, oliguria, platelet count that is less than 1 liter per cubic millimeter, serum creatinine more than 1.1, increased or elevated liver enzymes, persistent severe pain, convulsions or visual disturbances, IUGR, and pulmonary edema. Preeclampsia can also be divided as early onset and late onset preeclampsia. Early onset is when the preeclampsia occurs in less than 34 weeks of pregnancy, whereas late onset is when the preeclampsia occurs at more than 34 weeks of pregnancy. Early onset can be detected or diagnosed by uterine artery Doppler. This has been a question, so I included it here only. Next, as we know, magnesium sulfate regime is followed in case of severe preeclampsia or in case of eclampsia as well. In this, there are two regimes, the Pritchard regime and Jaspan or Sebai regime. Pritchard regime is intramuscular one in which the loading dose is 4 grams, 20% solution IV over 3.5 minutes, followed by 10 grams, 50% solution deep intramuscular, 5 grams each in each buttock. And the maintenance dose as 5 grams, 50% intramuscular, 4 hourly in alternate buttocks. Next, there is Jaspan and Sebai, which is intravenous, where the loading dose is 4 grams intravenous slow over 15 to 20 minutes, whereas maintenance dose is 1 to 2 grams per hour intravenous. A urine output of 60 milliliter per hour is an indicator to stop magnesium sulfate to prevent the impending magnesium toxicity that we will be further discussing. The benefits of magnesium sulfate: it has a neuroprotective action towards the fetus. It prevents seizures, prevent placental abruption. Magnesium toxicity will be loss of deep tendon reflexes. There will be decreased respiratory rate that is less than 12 per minute. Urine output will be less than 30 milliliter per hour. And the patient will complain of visual changes, flushing, muscle paralysis, and drowsiness. The management for this magnesium toxicity is giving calcium gluconate 10 milliliter, a 10% solution. The disease HELLP defines itself on its own, that is H for hemolysis, EL is elevated liver enzymes, and LP is low platelet count. So this usually occurs in patients with severe preeclampsia, where the clinical features are right upper quadrant pain, nausea and vomiting, with or without hypertension and proteinuria. There is a Tennessee criteria that helps in the diagnosis of HELLP syndrome, in which platelet count should be less than 1 lakh per millimeter cube. AST and LDH, those are the liver enzymes. So AST more than 70 international units per liter, LDH more than 600 international unit per liter. And the last one is hemolysis. Hemolysis will be present here. Prompt delivery for more than equal to 34 weeks should be done. Vaginal delivery if cervix is favorable. Platelet transfusion if less than 50,000 per millimeter cube is the value of platelets. Magnesium sulfate should be given as anti-seizure prophylaxis and antihypertensives for severe hypertension. The complications like eclampsia, placental abruption, hepatic subcapsular hematoma, and coagulopathy can occur in this disease. The hypertension in pregnancy, most important risk factor for abruptio placenta. So there's spasm of decidual spiral artery that lead to endothelial damage and extravasation of blood in the placental bed. That leads to fetal distress, and the clinical features in this are abdominal pain, vaginal delivery, uterine tenderness with frequent contractions. Based on the degree of placental separation, there's a grading that is 0, 1, 2 and 3. In 0, the patient is asymptomatic and is diagnosed after delivery, whereas 1 means vaginal delivery with mild uterine tetani, and 2 means the bleeding with fetal distress or death, and the third with maternal complications like shock, renal failure, coagulopathy and or death. So the immediate management that we have to do in abruptio placenta is giving IV crystalloids, arranging blood for transfusion and control blood pressure. According to the status of the patient, there's procedures that we can opt for. For example, patient in labor, the cervix favorable, fetal heart rate reassuring or dead, we can opt for amniotomy and vaginal delivery. Whereas if the patient is not in labor and fetus in its distress, emergency C-section should be done. The three small topics regarding this disease in pregnancy are: the first one is placenta accreta, where there is abnormally implanted, invasive or adhered placenta present. There is partial or total absence of decidua basalis and imperfect development of Nittabuk layer. That a Nittabuk layer is a layer of fibrin between compact endometrium and cytotrophoblastic shell in the placenta. This is absent in placenta accreta. The variants present here are placenta accreta, placenta increta and placenta percreta. Placenta accreta, where the placenta is attached to the myometrium. Placenta increta, where villi invade the myometrium, and placenta percreta when villi penetrate through myometrium to serosa. The next small topic is placenta previa, where there are the classification as 1, 2, 3, 4 according to where the placenta is implanted. For example, low implantation placenta is 1, then comes marginal, then partial or incomplete, then complete or central or centrally placed placenta. There are two kinds of management. Those are expectant and definitive management. Expectant management, also known as McCaffey and Johnson regime, where the criteria is that blood should be available for transfusion when and wherever needed. Facilities for C-section should be there so that whenever it is needed in emergency, we have to do it. And up to 37 weeks of POG should be there. The period of gestation should be up to 37 weeks only. So expectant management can only occur when the POG is till 37 weeks or less than 37 weeks. The suitable cases for which expectant management could be done is good health of or maternal good health, that is hemoglobin more than 10 grams %, duration of pregnancy is less than 37 weeks, no active vaginal bleed, and the fetal well-being is reassured by ultrasound and cardiotocography. The definitive management here is done in cases where bleeding occurs in more than equal to 37 weeks of POG, patient is in labor, and there's continuous bleeding of moderate volume. Fetal status is non-reassured. When placenta previa is confirmed on ultrasound, always C-section is the motto. Drug of choice for next one's hyperthyroidism, where the drug of choice or hyperthyroidism, or we can say it thyrotoxicosis and pregnancy, where the drug of choice depends on the trimester you are in. So in first trimester propylthiouracil, in the second and third trimester methimazole or carbimazole. But methimazole and carbimazole has teratogenic ability, so that's why it's not used in first trimester. So what are these teratogenic effects? The first one is aplasia cutis congenita. They can cause it, coagular atresia, transesophageal fistula, and fetal goiter. These are the teratogenic effects of carbimazole and methimazole. The one and small thing that we left is this one. The placenta accreta we discussed have some complications like what we should be warning the patient about. These are peripartum hysterectomy because of risk of hemorrhages during the surgery or operation. Next is blood transfusion, and the last one is bladder injury. This is the last thing we left here.